Thank you, Dr. Jyoti sir, for this wonderful opportunity to speak in JPEF, and I'm very honored to be the first speaker today. Today, I will be talking regarding the current practice guidelines. I'm just going to give you an overview of it. So, a patient comes to you, and the patient is having diabetes mellitus. So, what are you supposed to do? You have guidelines put forth by ADA, IDF, RSSDI, etc. And why do you need these guidelines? It makes it easier for your diagnosis. Classification is given properly in it. It addresses the comorbidities the patient might be having, complications, best treatment choices, and can this condition be reversed? That is something I will come to later. And if you look at, this is a screenshot from IDF Atlas, and it's showing that in coming 20 years, the amount of cases is going to be drastically increased. Um, and so who do you want to screen for diabetes? Obviously, older people, more than 45 years of age. If anybody is having CVD complications, any family history, if there is obesity, overweight, a sedentary lifestyle, and always one important factor is ethnicity. And in this, I'm showing you the difference between a Caucasian and an Asian. The Caucasian has more subcutaneous fat, but the Asian has visceral fat. That is a cause for diabetes. So we have to screen these people. So classification of diabetes, if you look at your textbooks, you will have a huge list of classification. So your guidelines is going to make it simple for you. Your guidelines have type 1 diabetes, type 2 diabetes, gestational diabetes, and some special cases like your MODY, LADA, your cystic fibrosis, FCPD, and drug-induced diabetes. So in treatment, the most important factor is you have to have the best outcome for the patient. You have to address the complication, the cost concerns, and the patient should be compliant with your treatment. So these are your weapons at hand: your sulfonylureas, your metformins, thiazides, your alpha glucosidase inhibitors, your DPP-4 inhibitors, GLP-1, and SGLT2, which I'll be coming to later on more. And this is your insulins. You have your rapid, short-acting insulin, intermittent, and long-acting insulins. The only thing you have to remember is that aspart, lispro, and glulicin, which is your rapid-acting insulin, works for 2 hours or 4 hours, and it acts very fast. So it is given as a bolus before meals. Then when it comes to the NPH insulin, it acts up to 12 hours. So it is most commonly found in your biphasic insulins. And then you have your basal insulins. This is the glargine. It has a very steady basal for up to 24 hours. So it can be given as once daily bolus. Sorry, basal. This is your FIASP. FIASP is something new. It is an ultra fast acting insulin. So it is given. It can given even 5 minutes before food, and your Tresiba is regular. It acts up to 40 hours. So it's a very good insulin. Even your patient misses 1 day of injection, it is fine. Tresiba will cover it. And if your patient is having cardiovascular issues, what are you going to do? Diabetes is actually a vascular disease. So we need to address that in our treatment. And SGL2 inhibitors and GLP-1 inhibitors are very important in treating people with cardiovascular risk. And also to prevent cardiovascular risk, studies have shown that the 3P MACE have been significantly reduced by using these treatments. So the pumps and pipes, I'm sure you will come across this term throughout the other sessions. And pumps refers to SGLT2 inhibitors. So SGLT2, on top of controlling your blood sugars, it improves the heart functions and prevents cardiomyopathy. And your GLP-1 refers to the pipes. And the pipes means GLP-1 on top of blood sugar control, it lowers your lipid profile and improves your BP and even prevents atherosclerosis. Your patient is having CKD, what do? You're going to give them SGLT2 inhibitors at the beginning stage of CKD itself. And this is showing that if a person is started on SGLT2 inhibitors, there's an initial slight dip, and then his renal functions remain stable. But in a case where a patient is not taking any SGLT2, for example, glimepiride given here, his values keep on dropping. So you want to give something like SGLT2 inhibitors in cases of CKD that is mentioned in the guidelines. I'll come to it later. And also you have to make sure you titrate the doses of your OHs to make sure the patient doesn't go into hypoglycemia. So coming to hypoglycemia, your elderly patients, your patients with comorbidities like CKD, CAD, and your type 1 patients are commonly seen to have hypoglycemia and are at higher risk. So hypoglycemia is very dangerous. The best things you can do is give them newer analog insulins, which are proven to have very low hypoglycemia. And frequent monitoring of blood glucose is very important to keep their blood levels stable. So this is a guideline by ADA. So here you can see ACVD risk. If the patient is having ACVD risk, guideline says give GLP-1, SGLT2, either of it or both of it. So you have to keep your blood sugar levels in the target range using GLP-1 and SGLT2 in ACVD. That is the best possible way. And CKD, obviously, like I told, SGLT2 plays an important role. And in hypoglycemia, DPP4, GLP-1, SGLT2, thiazides, all are effective, and it does not cause much of hypoglycemia. So the guidelines are given like that, and I hope everybody would go through it. And if your patient is concerned about weight loss, and if you think the patient is going to benefit from weight loss, metformin, yes, they say there is a little bit of weight loss, but SGLT2 inhibitors are having significant visceral fat reduction. And GLP-1, obviously, it is a drug that can reduce your body weight, and diet restriction is always advised. If the patient is saying, doc, I cannot afford this treatment, this is too expensive, you have to shift to something like metformin. Metformin is obviously a baseline treatment. It's very cheap. Teneligliptin and vildagliptin is some of the cheaper DPP4 inhibitors. Remogliflozin is a new SGLT2 inhibitor. It's available in India, and it's comparatively very cheaper than other SGLT2. So you should give to patients who will benefit from giving SGLT2. And obviously, you know, the human mixed-chart and insulatard are comparatively cheaper. So this is from ACE. And recommendation, as you can see here, after metformin, GLP-1, SGLT2, and you see sulfonylureas or secretagogues, they are put at the last, because you want to keep it at the last, so that because sulfonylurea have proven to decline patients' conditions, and you don't want that. So always you see GLP-1, SGLT2, GLP-1, SGLT2. So that's a preference you can see here. And RSSDA has put out a therapeutic wheel that is again in the RSSDA guideline, and it is showing about that Indians are more prone to vascular complications. This is the RSSDI therapeutic wheel. So in this, different factors can be put, and ideal treatment can be taken out for the patient. So reversal of diabetes, is it possible? Definitely. Reversal of diabetes is possible if you treat the patient as early as possible in the right way. Diabetes UK has shown that 15% body weight reduction can cause reversal of diabetes. And obviously the GLP-1 is a fantastic drug that can be given. Example, this is liraglutide, to reduce your body weight, and also it can reverse diabetes and control blood sugar. This is a study, just showing you this. This study is done in JDC, Jyoti Dev Center, and here the A1C from 7, it has gone down to 5. So this is kind of like remission. This is a remission that is taking place at just over 24 weeks. So early initiation of insulin is always very much needed, and the chances of remission is also seen if you do early initiation of insulin. And HbA1c, ADA said less than 7%. Then ACE said that it should be less than 6.5. Then ACP said 7 to 8 HbA1c if you suspect hypoglycemia. So A1C values keep on fluctuating a little bit, but basically, you know, it's 6.5 is the ideal range to keep it at. So time in range. Time in range is a new thing, and it has come up in the ADA guidelines also. And it's in the guidelines saying that your blood sugar should be within 70 to 180 range 70% of the day. So it has given several guidelines for this, and time in range is becoming very important nowadays. And it is something that we should do more often and try to do more often with our patients. There are a lot of studies going on regarding time in range now. It's a very hot topic these days. And these are some of the devices that is used. For example, this is Libre, Dexcom, and Eversense. These are the CGM devices they are going to use to do that. And finally, I just want to say about looping. So this is something I really personally love very much, and I'm very enthusiastic about learning more about looping. So what looping is actually is the CGM device connects to an insulin pump via a smart system like a mobile phone or a small computer, and the data is used to give an adequate, or it changes the bezel of the pump quite frequently, so that the patient does not have to touch the insulin pump to do any modifications. And it is all it works like an artificial pancreas, a pancreas which is outside your body but works just like a pancreas. So that is looping. So looping is the next big thing, and it is a cure for type 1, I would say, and it is going to be a great thing in the future, and I hope more things develop on it. So by that, that's it. I would like to say for today. I hope you take up something from these guidelines. The guidelines should be very essential in treating your diabetes patients. Look at the guidelines, and it will help you definitely in taking the right decisions to treat your patients, and give a very good outcome for them. And your patients are your priority. Okay, that's it for today. From me, thank you very much. Stay safe. And thank you, everyone. I thank everyone in the JPEF committee for this opportunity. I thank my Professor Dr. Jyoti Dev, sir. He's my mentor and my inspiration. Thank you, sir. That is it for today. Thank you.